Hello there, Catherine. How are you?
Morning, how are you?
Very well, thank you. Lovely to connect with you.
It's so lovely. Thank you so much for agreeing to do the podcast and providing your insight and expertise. I'm really excited to dive into this conversation. Where are you calling from right now?
Well, today I'm in Boston.
Okay,
So,
today.
yeah, so today. Normally I'm in Australia, but today I'm in Boston.
Okay, well, welcome to Eastern Time. So, hopefully you're okay and the jet lag's not too much, the time change.
Thankfully, yes. No, I arrived about a week ago.
Oh,
So,
good.
yeah, so I'm okay. I've been living in between, I've been traveling back and forth for the last 3 years. So
Oh,
it's been,
okay.
yeah, it's something I'm quite used to now.
Oh, good. Okay,
Whereabouts
yeah.
are you?
You gotta get used to that. That's for sure. I'm in Atlanta. I'm just underneath you. I'm been here for about 13 years, a Florida native. So
Oh,
this is cold for me right now.
I
At 50
know.
degrees. Yeah. But
I know. It's not pleasant. Not pleasant. The weather is the one thing about Boston that I go, "Ugh, really?
yeah, I know. I thank
That
you.
is
I
it."
know you're busy and I think this is going to be such a valuable conversation, especially for the loss community as far as baby loss. But I do speak to a lot of women who have reoccurrent miscarriages who will not get answers because most doctors here in the US won't even talk about it until there's been multiples. And then we have a lot of secondary infertility after having
Yeah.
living babies or having a term stillbirth and just cannot get pregnant again. So
Yeah. Yeah.
those are the topics that I we talk about a lot here, and
Yeah.
I
Yeah.
love your expert insight and all of that. So,
Absolutely.
yes,
Absolutely.
thank you again. I'd love to know how you got into this field. I mean, it's very specific, and are a
Yeah,
lot
it
of
is.
people doing it in this field?
Look, my speciality is really focusing on people who have tried for more than 2 years or experienced recurrent miscarriage or recurrent failed treatments. So I don't think that there are a lot of people who actually work at that very
Hmm.
other end of the equation because most people conceive without trying.
Hmm.
In the general population, 93.6% of people who are trying to get pregnant conceive under 12 months.
Mm.
And so what happens is that for the people who don't conceive under that 12-month period, they typically are very different to the people who I see who have been trying for 2 years or more.
Mm.
Right? It's like the longest standing case of infertility I've ever treated was 19 years, and that
Oh.
woman had a pregnancy and a live birth. But typically, I'm treating people on average for who have been infertile for 4 years.
Mm.
And I know this because, part of my master's at Harvard, my master in public health, I actually did my thesis was all about the types of patients that we were treating and who we were basically helping. So, in a cohort of 544 patients, what we saw was exactly this: average of 4 years of infertility, 51.5% miscarriage rate prior to treatment. That went down to 13.5% after treatment.
Okay.
And almost 50% of people had previously failed IVF cycles and then went on to conceive naturally. So I
Wow.
guess, when you ask the question, and in that cohort of 544 patients, we had a 78.8% live birth rate, So are there many people doing this kind of work? Well, I don't typically see
Mm.
a direct comparison, between what it is that we do versus what other people are doing out there. I certainly know that when it comes to integrating, you know, diagnostics and treatment, and having reportable results, I don't see that very frequently at all. In fact, I've never seen it. So what got me into it actually was not by design. It was it was actually my patient's experiences that led me to decide, okay, there's something here. And what had happened was actually the lady who I treated who had been infertile for 19 years was a pivotal moment in my career because just before her, before these two patients that I always think about when people ask me, how did this start really? I always, my mind always goes back to these two women because before them, I was treating people to improve their chances of having a baby. But really, there was people who were kind of trying for about 6 months to under 12 months before they went and did IVF. And I did that for many years. And then, I obviously developed a reputation for helping people prepare for conception and miscarriages was something that I was already treating. And somebody referred this lady who had been trying for 10 years without success. And when she first came to me, she was like, look, I've tried 10 years. I've had multiple failed IVF cycles. I literally want to like stop. I want this part of my life to just like either I have a baby or I don't and I
Mm,
move on,
mm,
you know. And I could see the sense in that. I was like, yeah, okay, that makes sense. And she said, and I want you to treat me so because I want to go and do my last IVF cycle. And I was like, I don't know. If you've had multiple failed IVF cycles, I don't know that what I do actually is going to really help you. And she said something that changed my life. She literally said, listen, I'm about to give up anyway. So I just want you to help me be healthier so that I know that I've done everything I could. I was like, okay, I can do that.
yeah.
That's something that I can definitely do. And so I basically just went into it doing the work that was required. And once that actually went underway, what was fascinating is that about 4 months later, she was pregnant for the first time ever, naturally, with her own egg and sperm. And by this stage, she was being told that she needed donor egg and all of these things. And so it was really interesting to me to go, wow, it's an interesting coincidence, like
Yeah.
10 years of infertility and doing this. I really didn't think that was because of what I had done. And so I just kept going on with my life. And a couple of months later, I had this other lady come in and like 19 years. In fact, she wasn't really that excited about treatment. Her husband was dragging her there. And she was like, this is the last time I'm doing anything. Imagine she also had had multiple failed IVF cycles. And so,
So heartbreaking
you're
every
kind of
single
like,
time. Yeah.
in 19 years, who goes for 19 years looking at, negative pregnancy test after negative pregnancy test for 19 years. Like I couldn't even imagine, like honestly. And so in the end, we've decided, okay, let's treat, let's see what happens. This is the last hurrah. If it happens, it happens. If it doesn't, it doesn't. And again, under 6 months, she was pregnant for the first time with her own eggs. And, she ended up having a live birth and a healthy baby. And at that point, I was like, okay, this is too much of a coincidence, very
Mm,
close together.
mm-hmm.
And so that was what made me go. And what was interesting, I actually loved treating those two women because the anxiety of I have to be pregnant by tomorrow that people experience under 12 months was
Mm-hmm.
not there at all. It was just like, you know what? I'm kind of done anyway. I just want to know,
Mm,
that when I'm 90, sitting on my porch in my
mm-hmm.
rocking chair, that I can look back and say, I've done everything. I
Mm,
want to have no regrets, right?
mm,
And so that was a very different energy. And to me, that was really appealing because it felt lighter.
mm-hmm.
Even though there were really difficult, complex cases, it just felt like, okay, you know what, I can have this conversation for the next 20 years. And
Mm-hmm.
so that's how it began. And I at that point transitioned from preparation for conception and reducing miscarriage risk to going, look, I really only just want to focus on the really difficult, complex cases of people who have been trying for 2 years or more.
Mm,
And so I started to position what I was doing in that way. And that was about 15 years ago,
mm,
and since obviously we've now helped thousands of couples overcome infertility, recurrent miscarriage, and failed treatments, really using my proprietary methodology that really focuses on diagnostic first.
mm,
It's
mm-hmm.
really focusing on, okay, what is the fact finding? It's called the Fertile method, and the F stands for fact finding. Because what I know is that when you go to standard therapy, when you go through, haven't been able to conceive, let's go and see a doctor about it. The very next recommendation is, yes, you need to do IVF. And what I often see is that
Mm-hmm.
people have suboptimal results and
Mm-hmm.
are being told everything is normal, just keep trying.
Mm-hmm.
Now, maybe it's the skeptic in me that thinks that, everything is normal, just keep trying is a wonderful strategy for shareholders, of
Mm-hmm.
IVF clinics
Yeah.
who will benefit from that strategy. But on an individual level, I don't think that couples benefit from that strategy. And something that you've just talked about that I think is really important to highlight is that it's not just in the United States that couples are expected or women are expected to have at least 3 failed pregnancies or miscarriages before they actually get investigated. And sometimes they don't even get investigated thoroughly enough
Mm-mm.
so that you don't find the causes that, essentially are leading to that miscarriage risk or
Mm-hmm.
rate. And you just keep repeating more of the same. Now, I don't have to tell you that you only need to go through one pregnancy loss to be traumatized for life, really,
Right.
for in many cases. And
Mm-hmm.
so ultimately, who wants to go through 3 before you even get investigated? So we don't allow that for our patients. Like we really very precisely look at, okay, what are all of the things that we need to understand to rule out that potential outcome? And how do we need to then manage that process in such a way that it leads to the most direct, fastest path and most cost effective
Mm.
path to baby? Because as we know, repeated IVF failures, and it's interesting because there's a lot of data, population information, population data on IVF cycles, and we know that on average to have close to an 80% live birth rate through IVF, you need on average 8 IVF cycles. Imagine
Oh
in
my
the United
goodness.
States where the average cost of an IVF cycle is anywhere between $15,000 to $30,000. Most people are priced out of having a baby even before they start, because it's just one of those
Well,
really crazy things.
and you have to have 8, for lack of a better term, good embryos. And are you seeing any correlation with the diagnostics equivalent to maybe not so many great embryos or having to do it over and over again in order to create more and more of them before they can even implant? Or are you seeing that?
You see, and this is the thing, when you look at the data, and this is what so many people don't understand before they go into IVF because they think that, okay, it's the standard therapy, it's the gold standard, therefore it's a magic bullet or it's the silver bullet. It's the thing, I'm going to do that and it's going to work. But the truth is that, and again, this is not me saying it, this is published data, on average, in general, most IVF cycles, like to the tune of 71 to 86% of started IVF cycles don't yield a live birth
Wow.
across all ages. Okay. So, and again, it will be differential depending on complexity of the case, on age, on sperm
Mm,
parameters, and a whole lot of things. And if you think about what happens, on the journey, even when you have pregnancy loss of any kind and stillbirths and so on, what's often the focus of all of that is the woman and what's happening in her body.
mm-hmm,
And the male factor,
mm.
which is 50% of the fertility equation, is completely disregarded,
It's
for
true.
lack
Yeah.
of a better, word. And so we are trying to address a very difficult, complex issue that takes 2 prospective parents to create a healthy embryo and a healthy baby, but only looking at 40% of that equation. Because you see, if we look at the whole picture, 40% of reproductive challenges are to do with egg and female factors, 40% is to do with male factors, and 20% is to do with embryonic factors
Mm,
or environmental implantation,
mm,
all of those kinds of things. You can't do very much once you have an embryo, unless you're dealing with immunological reasons as to why fertility, pregnancy is not continuing. You can't do very much with that. Once the embryo is formed, that's kind of what you have, right? So you have to really look upstream from that. You have to look at the egg, you have to look at the sperm. But even that isn't the beginning, because in a biological system, you have biological inputs.
mm.
And so what happens is that you have lots of biochemical chain reactions that happen to even lead to an egg and a sperm. let
Mm.
alone to lead to an embryo and a pregnancy and a healthy baby. So if you are looking at just, do I have a positive pregnancy test? And if you're only looking at the female, you've just left a whole lot of fertility potential on the table.
Yes, absolutely.
Okay? And so when you ask me the question, am I seeing these correlations of, embryonic development and quality and all of those things with failed IVF cycles or successful IVF cycles? 100%. And you can understand now why. Because
Why?
there's
Right,
so much
right,
there that we need to take into account when we are looking at having the outcome that we want, which is a healthy baby.
right, right. For my personal experiences, I was something on my son's like pathology. My doctor was like, let's do testing for blood clot disorders. And I was like, a what? Because she saw maybe a correlation with his death with a blood clot in the
Yeah.
placenta or in the cord. So I'm going somewhere with this. And I was like, okay, so now what do I do since we decided that I do have factor two prothrombin gene mutation? I do
Uh-huh.
have a four
Yeah.
time more chance for
See.
clots, which I did not know I had before his death.
Yeah.
She's like, we
Yeah.
we don't treat. You have no known clot, so we do not treat moving forward. And I was like, you got to be kidding me. So my point
Wow.
is if so I ended up going on Lovenox by choice. I forced my doctors to go for
Good.
my two pregnancies after that. Now my point is that if they were like, "Oh, we don't treat." Okay. Then I was like, "You know what? I just want to have a living baby. I want to cut to the chase and do IVF." I could have continuously lost those embryos to clots or anything going on and not even known without that test. So that's insane
100%.
to me.
And this is what happens.
Yeah.
Unfortunately, like what ends up happening all the time for people is exactly what you've just described, is that the right tests are not done. Either the right tests aren't done, or some tests are done and not all of the right tests are complete, right? Or there is a misalignment in the interpretation of results where
Mm.
doctors are only looking at the reference range for the lab. I'll give you an example that happens all the time that leads to increased risk of miscarriage. Thyroid function test.
Mm.
It is so common that you see people with really elevated TSHs, which means that the thyroid is under functioning, and the reference range in the lab is between 1 and 5 international units per litre. Now, here's the thing, and there are plenty of papers out there to demonstrate that anything around 2.5 or more TSH increases miscarriage risk,
Mm.
right? And what's interesting is this, for the general population who may have a slightly elevated thyroid TSH that end up with a baby, that's great for them. But the people who have that marker and don't end up with a baby, it's not enough to do nothing,
Mm.
because there is enough information to understand that anything above 2.5, 2.3, 2.5 is going to increase the risk of miscarriage. So this is what I see very frequently, is that you might have a situation where you are not getting the outcome that you want. Inability to conceive, inability to keep a healthy pregnancy to term, whatever it may be. And you have some results, and the results are not in an optimal range, right?
Mm-hmm. Mm-hmm.
But because they are within the reference range, they're deemed normal. So what patients end up hearing is, we've done all the tests and everything is normal. That's actually inaccurate.
Mm.
When what is actually normal is you have sex, you get pregnant, you have a baby. Anything outside of that might be common, but is not normal.
Wow. 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 They do use that word a lot. It's normal. They use
It's
it all. I
normal.
think it actually
It's
says
like,
normal on the results. And you're like, what? It
yes,
cannot be normal. Yeah.
exactly.
Yeah.
Exactly.
Yeah.
And so in a situation like yours where it's factor five or it's prothrombin or whatever it may be, like any
Yeah.
clotting kind of disease, you are usually going to be dependent on the quality of the doctor that you're seeing and and look, I want to put this in this way. Doctors, they really do have their patient's best interest at heart.
Yes.
What often happens is that they either don't have the time, because how much can you do in a 5-minute consultation,
True.
right? They don't really have the time to really explore it in detail and to share decision making with the patient,
Mm.
to go through the pros and the cons. Look, if you do this, typically we might not treat, something unless we have clots. But at the end of the day, you have a pretty specific reason to want to have this looked at in much more depth and much more detail. It's not usual to lose a baby at 37 weeks,
Mm-mm.
right? And
Right.
so when that is already the history, I think that it's unacceptable to say that, oh, we're not going to treat this issue that we found that is correlated with miscarriage risk, is correlated with stillbirths. If there is a clot in the placenta, of course we're going to have an issue, right? I think that that's really where it becomes a little bit values and preferences from a patient perspective, and being able to actually be given those choices.
Mm.
First of all, the education and the understanding about what's available and what's possible, and then be given the choice to say, hey, listen, these are the pros of you taking this medication. These are the risks of you taking this medication. There is no real indication at this point, other than the fact that you've got a history of this issue. But this is a decision that you need to partake in,
Oh my God, thank
and
you.
it will come down to your level of risk profile, right? And also your peace of mind, right? It's like
Yes.
make you feel like, you know what, I have peace of mind moving forward.
And I
I
think
think
that's a huge part of it, the mental aspect of this. Yeah.
yeah,
Yeah,
it
we're
is a
consenting
huge part.
adults, and it's almost like they don't I that's all I'm asking for, what you just said. Give me all of the information and let me make a properly informed,
Informed
well-educated
decision,
decision. I mean, we
100%.
do that boarding an airplane, and even in the event that we're going down, we got a plan. Like, I would just have loved that. I don't understand why these tests aren't done prior to pregnancy. I don't know why we're not doing a baseline test as to
I
make
can tell you that.
sure. Okay, please tell me. Please tell me.
Can tell you.
You're the
The
pro.
reason is, yeah, the reason is that, it makes no sense on a population level
Yeah.
to do these tests as a matter of routine. It
Mm.
makes no sense because, like I said before, like most people will conceive, 93.6% will conceive and have a baby, and this conversation is never had
Yeah.
until that point. So imagine the healthcare system is constrained. There are budgetary constraints, there are lots of different things. In public health, it's one of those really difficult things.
Mm.
In healthcare systems worldwide, if the cost of treatment is the same as the cost of preventing that problem, guess what's going to happen?
Oh my God, treatment.
The money is not going
Gonna
to
go
go to prevention.
prevention.
The
Holy
money is
moly.
going to go to treatment.
Hmm.
So you name it, any health condition across the board, like diabetes. Diabetes is one of the highest, number one, like I think it's the second killer of populations around the world. If the cost of preventing diabetes and treating diabetes is the same, prevention is not going to be the focus in public health, right? And so, unfortunately, fertility is one of those really underserved situations because here's what happens. If it's only really going to be about 6% of people who don't conceive within 12 months, and then of those, about 96, by the time you hit 2 years, 96 plus percent have conceived. So then you end up with like a 3%
Yeah.
part of the population
Yeah.
that don't conceive. That 3% are the people who actually need much more investigations, treatments, all of that. But you see, it's extremely costly to provide that as part of the healthcare system
Mm.
because if a baby already costs, let's say, the healthcare system $30,000, and it's a little bit more, but let's say $30,000, having no complications and no issues. Okay.
Hmm.
That's for the people who conceive easily and everything goes well. Let's say that to the healthcare system, it will cost more than $200,000 for a couple who has infertility, miscarriage, like all of those things. That money is
Hmm.
just not there for
Mm.
vast numbers of people, you
Mm.
see? And so that's where people either have to choose to invest out of pocket
Hmm.
and pay for their own tests. And you see, if you're willing to pay out of pocket, you can have all the tests you want.
Mm.
You can have all of the things that you want. But then the problem becomes that the healthcare system itself is not structured to take people on that journey.
Mm.
That's very subspecialized and
Mm-hmm.
very specific. So
Mm-hmm.
it becomes a situation of like, imagine what other health condition is there? None, by the way, spoiler alert. What other health condition is there that diagnosis is self-reported by a matter of time? Imagine this. Imagine you go to your doctor and you say, I have cardiovascular disease. And the doctor will go like, okay, how do you know that? Well, you can go and do very specific testing to ascertain if that is true or not.
Mm-hmm.
With infertility, you do not need that. You can literally just say to your doctor, I have been trying for 12 months and I have not conceived. There you go. You have infertility. That's your diagnosis given. Okay.
Yeah.
So then what happens is that you really have to have 4 tests from for a doctor to comply with healthcare system guidelines. They need to run an ovulation test.
Mm-hmm.
They need to know that the fallopian tubes are clear.
Mm-hmm.
They need to know that the uterus can hold a pregnancy, so there will be an ultrasound. Typically, they will do STI screening, typically, not always. And I'll tell you a story about this. It's crazy. And, they will recommend a man to have a semen analysis. That may or may not happen because
Mm-hmm.
depends on, if the wife goes to the appointment, the husband's not there, the doctor is not going to give a referral to the husband. They're going to be recommended to go and have, to see their own doctor to go and get the test. Most men are going to be like, oh, I'm fine. I don't need that, you know. And so
Yeah.
that test usually is not done. And so let's say you have those 3, 4 tests completed. There are 4 out of 1,000 different
Mm.
tests that you can do to really pinpoint what's going on. Now, you have all of those tests done. It's atypical to really find many problems in those 4 tests. So, what then happens is that the patient is told, we've done all the tests and everything is normal.
Mm.
What? I beg your pardon. That is not all of the tests.
Mm-mm.
And is everything really normal? Well, we don't know. If you're not conceiving, then the answer is no, right? If you're not keeping a healthy pregnancy to term, then the answer is no. But patients will be told that that is the case, and they will usually believe it because, well, the doctor said. So that's what I'm going to go with. So those are a lot of different challenges, that people face on this journey. And unless they are advocating for themselves and they're going outside of the healthcare system to look for the help they need, they're not going to get it within it, unfortunately.
And it doesn't feel like doctors within the healthcare system are actually suggesting that they do that or referring them to somebody.
No, no, because you see, unless there is a high level of and quantity of evidence to suggest that there is a benefit in doing something else, then that is not going to be a recommendation. And when there is no money or funding to actually run those kinds of
Yeah.
trials, then guess what? You never have the evidence. So, it's a chicken and the egg situation. You
Yeah.
see, that really does not serve and benefit patients. A lot of the time, I often say, it's the Wild West out there when it
Yeah.
comes to fertility. It's like each man for their own, and good luck with that. So, and here's a good kind of case to wrap this up and to give you a little bit of a context. I had a couple once who basically came to me. They were trying for 14 years.
Oh my gosh.
The first 8 years, they basically tried just by not using contraception. They just kept trying and, kind of hoping for the best, seeing how it goes. She was a pharmacist. And at that point, she was like, you know what? It's been 8 years. I think we better do something. Okay. So then they started treatments. And as they started treatments, they did 6 IUI cycles that didn't
Mm-hmm.
work.
Mm-hmm.
And then they went on to do another 2 IVF cycles that didn't work. And by this point, she's being told, oh, it's an egg quality issue. You're old. And I'm thinking, well, you didn't start that way. So, clearly after 14 years, yeah, I mean, that could be feasible. But anyway, so I started to look at, I always assess every single case coming into my clinic because we know the types of patients that we best serve and we stick to those. So in my assessment of their case, it was the funniest thing because I literally am talking today with the guy and I say, so is this the first semen analysis that your count was low? And he goes, what do you mean? I said, your sperm count, it's only 2 million. It should be at least 20 million. It's low. He's like, oh, nobody ever told me that. I
Oh,
was like,
what?
what? Mind blown,
No.
right? So like 14 years of trying multiple treatments that haven't worked. Nobody ever told him he had a low sperm count. Okay, fine. I can understand that could happen. That's fine. So then we continue investigating, and there were lots of complicating factors. She had diabetes. There was lots of other things that were coming in the way. But one of the things that through our workup we found out is that they both had a silent infection that was known to cause infertility and miscarriage. But I was like, I cannot believe, like, nobody had screened them properly for STIs,
Oh
and
my God.
literally they didn't know. And so they had been together for all this time and they had no idea. So of course we get them on, like, they had to go on seriously high doses of antibiotics and a whole lot of other things to be able to actually address this issue. But after we did, they conceived first attempt
Oh,
naturally
oh, my mouth is
without any
open.
other issues,
Oh
like
my God.
literally. So, this is essentially what patients unfortunately go through and endure when they don't know what they don't know.
So this is you. This is you. This is what you do on the outside of the healthcare system when you say that there needs to be specialists to look into this.
Yeah.
How does your program work if someone were to come to you?
So the first thing that I do is I assess, right?
Mm,
I fact find. I get them to complete a really comprehensive questionnaire. I look at the results tests that they've had done, the history that they have, what is it that they're looking for? Because again, my biggest thing is about helping people have all of the information they need, so that they can make the best decision for them. So values and preferences is the number one thing. I will often ask people, so how are you intending to conceive? Sometimes people come to me because they want to prepare for IVF. Sometimes they're coming to me because they want to prepare for donor egg. Sometimes they're coming to me because they only want natural conception.
hmm
So it depends on what it is that they need. And then, of course, by me understanding those pieces, I can then make recommendations. And we use, essentially the best of both worlds. I'm originally trained as a naturopathic doctor, so I utilize all of that
mm,
plus everything that the healthcare system has to offer, right? So I'm using diagnostics that are very advanced in many ways so that we can understand what are we actually dealing with, and once we
mm,
do understand that, then we put together treatment recommendations that make a difference to that particular situation. Because otherwise, what we're doing is we just keep going around in circles, hoping for a different result. And
hmm
hope, unfortunately, isn't a strategy. That does not lead to getting the outcome that we're looking for.
No. Do you have mamas like me who come in who are severely traumatized, grief ridden, anxiety drenched in stress because they've had a loss, but they've never had quote unquote fertility issues before, but just can't seem to conceive again after their significant loss?
Yeah, it's really interesting that you asked that question because my doctoral project, so I'm doing my doctorate at Harvard in public health.
hmm
And my doctoral project is actually an intervention to address infertility related trauma,
Mm.
grief, and stress, specifically for this kind of situation where
Oh
people
my.
have, really gone through very difficult situations. In fact, if people want to find out more about that and they want to enroll in the study, we are enrolling now. We are definitely recruiting for it.
Oh wow. Okay.
The URL for the website is inspirestudy.online. So they can just put that on a browser, inspirestudy.online. And we're using a writing intervention. It's shown to be very effective in treatment of chronic symptoms of PTSD and all sorts of things in other populations, but there's been no studies in the reproductive kind of challenges population, so to speak. And so we're doing that as a first study. And but because it's so important, if we're not addressing the emotional component, there's a wonderful book by a Boston University researcher called The Body Keeps the Score.
Oh yeah, I got
You
it right
know,
here.
yeah, there you go.
Yeah,
Yeah. And so, it's one of those things. If we're not addressing those emotional components, they're going to have to go somewhere.
right,
Right. And
right.
so understanding and addressing those issues is really important. It's a very important, kind of additional piece of getting results. And of course, again, that peace of mind component, you cannot underestimate the importance of really being able to feel relief
Mhm.
from all of these really difficult emotions on this journey and beyond, and beyond. I think that's such an important part.
And that's you're in their corner. You feel you seem so passionate about what you do and that you genuinely care about your patients. We're finding, unfortunately, that we are being brushed to the side. Oh, it was a freak accident. Oh, it'll never happen
Mm,
again. You'll never get answers. And then they don't follow up with us. They don't even really it seems as if they don't really want to invest in what happened and to help us have subsequent pregnancies. A lot of us are having to go find other doctors after our losses that will sit and listen to us and just support us,
yeah,
not just physically, but emotionally and mentally. Like you said,
yeah,
I think that
yeah.
helps a lot in relieving that anxiety and stress when you know your doctor's in your corner or you know you have somebody who's willing to give you answers.
100%. And who will literally navigate that process with you, because
Yes.
it is a challenging, navigating the healthcare system through its various twists and turns.
Mm-hmm.
It is very, very difficult, especially if you're not trained in doing that.
Mm-hmm.
If
Mm-hmm.
if that's your training and that's what it is that you do for work, of course it's going to be a lot easier for you to know what are the questions I need to ask, who do I need to go to, what is the help that I need, and find that help. Most people don't have that privilege.
Mm.
They don't know where they need to go or who they need to ask or how they're going to get the help and the support that they need. And that is one of the most stressful components of going through infertility and miscarriage, because you live with this ongoing question: will I ever have a baby?
Mm.
Will I ever complete my
I've
family?
been there. Yeah.
Will Yeah, and it's traumatizing and devastating in its own right without you losing a baby,
Mm-hmm.
right? When
Mm-hmm.
that happens, and then when you can't conceive again afterwards, those questions only escalate, right? And
Mm-hmm.
it creates an immense amount of stress that needs to be addressed, because otherwise you end up in a situation that is much worse than when you
Mm.
first started.
Mm-hmm. Mm-hmm. Are you finding, you said you've been doing this for 15 years. Are you seeing an,
No, I've been,
oh,
it
sorry.
would be nice. I've been doing this component
Oh,
for
this
15 years, but I
component.
actually
Okay.
I've been practicing since 2001.
Okay. Okay. So
So
have,
24 years.
oh, girl, you know your stuff because you've probably seen a lot of changes. Or maybe, I guess my question is, have you seen an increase in infertility and recurrent miscarriage in the last few years, I would say?
Look, and it's really difficult to see those changes in short periods of time, in short
Mm-hmm.
increments. And short is generational,
Mm-hmm.
right? And so basically that means every 20 to 25 years is where you start to be able to see trends. What I can say is this: when I first started doing this work in 2001, what was possible then versus what's possible now has drastically shifted, but not all in good ways.
Mm-hmm.
Okay.
Mm-hmm.
And so here's essentially how this transitioned. Back then, you could put in and be willing to put in enough time, energy, effort, and money, and you could still end up with no baby at
Mm-hmm.
the end of all of that, right? 2025, you can put in enough, and beyond, you can put in enough time, energy, effort, and money, and you will end up with a baby
Mm-hmm.
if you're willing to do all the things that you need to do to get that. I'll give you an example. Back in 2001, donor egg wasn't really commercially viable to the level and degree that it is now,
Mm.
right? Donor embryo wasn't even like the ethics of that whole process was still not figured out. These days, those are options that, are much more likely. Surrogacy was another thing that was not very easily, kind of accessible. Even though it's
Mhm.
expensive and it continues to be expensive now, those are options that are available that were never available before. Now, a lot of the effort goes towards high intervention kind of, treatments.
Mhm.
And the reason is that there is money in it, right? So basically for pharmaceutical companies, medical technology companies, etc., it makes sense, right, to have some kind of solution that is perceived as easy and effective and fast,
Mhm.
because that's essentially what people are willing to pay money for. And so the research goes there.
Mm. Mhm.
So the changes that we have seen over, or that I certainly have seen over that time, is not so much in the incidence of infertility.
Mhm.
There has been a change of people socially deciding and questioning whether they will want to have a baby.
Mm.
That's something that, has is much more a conversation now
Mm.
than it was back when I started. Like people these days literally question whether they will have children
Mm.
compared to how it used to be, where you just like, you grow up, you get married, you get, you have a baby
Mm.
and you have a family, and it's the white picket fence
Mm.
2.1 children, whatever it is that,
Yeah, right.
it was back then.
Right.
But basically now there is a situation that, and economically speaking, there's a lot of, Gen Zs and millennials and, all of that going, you know what? Can we really afford to have babies? Do we want to put babies into the world? Like, incredibly to me,
Wow.
that is a big conversation these days. Now, in terms of have there been more things come into our lives that now decrease our chances of getting pregnant? There is also an aspect of that,
Yeah.
endocrine disruptors.
Mhm.
There's definitely, we've seen population studies looking at semen analysis, dropping by half in terms of count because of these endocrine disruptors and estrogenic components in the environment. So, but is that the reason? Have we seen a much increased rate of infertility and infertile couples? Not so much.
Mm.
Not so much. So there is definitely correlations
Mhm. Mhm.
around, what's going on in the environment and sperm counts, for example. But has that actually led to less ability to conceive on a population level, at least? It's still halting at that kind of 1 in 6 couples
Mm.
experiences fertility challenges. And that has been a similar figure for, at least a few decades.
Wow. 1 in 6. Wow. So you listed all the options we have now, egg donors and surrogacy. What do you think is the future that will be an option for us? We've seen the articles, we've seen the movies. What do you think? Where do you think
Yeah,
it's going?
yeah, yeah. It's a very good question. Now, I think that one of the biggest places there's a lot of research, and for a good reason, is stem cells for
Mm.
creating and generating more eggs. And I think that, you see, the conversation today is that women are born with all the eggs we'll ever have. And then
Yeah.
there is a end window where we basically can no longer reproduce because we've run out of eggs. I think that in the next, I don't want to put an estimate of time on it necessarily, but I would imagine that in the next maybe 25 to 30 years, we will start seeing a situation where we will have that conversation be quite shifted to it no longer being about women can not generate new eggs, but having procedures and technology that will enable that. Now, we also know that there are really interesting research that is ongoing on being able to generate embryos and babies, from outside of the womb and in artificial wombs and, all of those sorts of things. And those are the kinds of movies that you're probably referring to. There's a
Wild.
lot of research. Yeah, there's a lot of research going on around that. And there are some claims that I don't know yet that I believe, but that, that is already underway in terms of it already happening in some countries around the world. I don't know. I haven't seen enough evidence yet to say that, is it one of those things that it's a far-fetched, when Dolly was born, the first kind of the sheep that was
Oh yeah.
cloned.
Yeah.
That was obviously a huge breakthrough. And when it happened, like there was a lot of talk about it happening
Hmm.
before it was actually, it's like literally 20 years before it actually happened, right? And so I'm in that kind of like, are we talking about Dolly here, where this conversation about certain components already happening, but the outcome of literally seeing a live birth from an artificially generated womb, has that happened yet? I'm unaware. If it has,
Okay.
please do let me know.
Oh boy, man. I don't know in my lifetime, maybe. There's some things I couldn't have predicted seeing in this lifetime, and here we are.
Isn't
So,
that right?
yeah.
No, I agree with you 100%. One of the other things actually that's
Yeah.
quite interesting based on that is like these, what is becoming quite a trend, which is people having relationships with AI,
Oh,
right? So the,
yeah. Yeah. To have
that,
an AI baby may not be out of the question. I'm just thankful that you are still of the camp of helping us figure out what is going on internally inside our own bodies based off of environmental external things that we have no control over that are even aware of happening, that you are helping us still have the chance to conceive
yeah,
and carry and have healthy living babies, and regardless of age, regardless of what's going on as far as you personally in the age and saying, oh, this is not going to happen for you, you're too old. People doing this for 20 years, they probably started in their 20s, they're approaching their 40s now and thinking it's over in that aspect, but it doesn't have to be. And
yeah,
you
yeah.
suffered massive losses. It doesn't have to be the end of you expanding your family. And I appreciate you so much staying in that camp to help us do it what could be considered the old-fashioned way, quote unquote, now. You know what I mean? Like, my goodness, let's
Oh
keep
my
it.
God, people actually have sex to have babies?
Isn't that funny? I know, right? And bringing up the whole male infertility aspect, because I know that to be absolutely true.
I
But
know,
I'm
yeah.
so happy you're here and willing to have this conversation. And I'll let you have, the last message. Is what would you like to say to any mother or parent out there that is going through this right now? What do you say to your parents, like maybe in the very first conversation of what do you need them to know before they start this
Yeah,
journey or as
yeah.
they're ending their first journey?
Look, I think that the most important thing that people need to know is that if you are not in the place where you had sex, got pregnant, had a baby, don't listen to everything is normal, just keep trying, or better luck next time, or it's a numbers game, because that is what costs people a huge amount of fertility potential
Mm,
in believing or hoping that that's true, knowing very, very well that it isn't, having that knowing sense of like, hang on a second, like surely like this, there has to be something, what has been missed. If you have that sense, listen to yourself, listen to your intuition. Don't let, the medical system gaslight you into, basically, oh, everything is fine, don't worry about it, you're being paranoid. Be paranoid, advocate for yourself, push, don't take no for an answer, and be willing to learn, because what keeps couples stuck on this journey is what they don't know. They don't know. I've been doing a program called the Fertility Challenge for 15 years now, where we educate people on all of these things that they need to understand and that they need to know to be able to move from that place of being stuck. And one of the things that I see all the time, I've now taken hundreds of thousands of people through that program. And what I see every single time is that people start to go through it thinking that they've heard so many times, oh, everything is normal, just keep trying, it's a numbers game, blah, blah, blah. And they end the 14 days that this program actually runs over going, oh my God, I didn't realize that there are so many other things that are within my influence that I could do. So again,
Mm.
educate yourself, advocate for yourself, don't believe what you're told, especially if you want to hold your baby and you're not, and you are doing everything that you've already been told to do.
You're so cool. I can't believe you started practicing when you were like 5. Like, this is insane.
Oh,
You
I
are
so
so
wish.
cool. I
Thank you.
really appreciate you. I really do. I really, really do. You've been so amazing to talk to. I could tell that you are just so into this, and I love that. And it's what we need. It takes hearts like
Yeah.
yours and brilliant brains like yours to help us in these situations.
Oh, thank you,
And
Catherine. It's so kind.
yeah, I'm gonna link everything so people can find you, but can you kind of give me an idea of how they can contact you or work with you?
Yeah. So I do a lot of patient education on my Instagram account, Gabriela Rosa Fertility. People can go to my website, which is fertilitybreakthrough.com for more information as well. And they can Google like Gabriela Rosa, Gabriela Rosa, fertility. They will find me.
Awesome. Easy. Thank you for keeping it super easy. Well, I thank you so much for coming on and doing this. I cannot wait to share your information with the mamas out there that are listening, and hopefully they can spread the word of what needs to be going on. All it takes is really just us not shutting up about it and continuing to be
Yeah.
loud about it, and really just
Yeah.
like you said, not taking no for an answer. The
Yeah.
saddest part about all of this is not knowing that you need to advocate against medical professionals sometimes, because
Yeah.
you trust
Yeah.
them, you respect them. We still do, but we do
Yeah.
have to advocate for ourselves in these
A hundred
situations.
percent.
Yeah.
That's essential. If
Yeah.
you're not getting what you want, it's not enough to just, lay down and take it.
Oh gosh, the old-fashioned way.
So, yeah,
Yeah.
exactly.
Yeah, yeah. Well, thank you so, so much. Good luck with all of the things that you're working on. I cannot wait to see what this study ends up finding that you're doing right now. I hope
Yes.
some mamas will enroll in it. And
Yes.
just following you on your journey as well. If there's anything that I can do to assist too, if you come across any mamas that need a little hand holding as far as their grief is concerned, please send them my way. I'm open arms for them as well as they navigate their next steps to having their family
And
that they've
that's so
thought of.
needed.
Yeah.
So, so necessary. So thank you for your work and the things that you do too. Because you know, I think that the biggest, most disheartening part of all of this is feeling alone on this journey. And this journey can be really
100%.
isolating. So
100%.
thank you
Thank
for what you do as
yeah.
well.
And I appreciate you for saying that. It's so true, for sure.
Amazing, amazing. Thank you so much. And
Thank you.
thank you for the wonderful conversation.
Absolutely. Hope to have it again soon. All right. Enjoy the rest of your day. Thank you for your
You
time.
too.
Okay.
Thank you.
Bye.
Bye.